Okay. I think that problem has been solved. Welcome, everyone. This is a webinar today on the Integrated Care for Children model, roles for advocates. I'm going to turn it over first to Elizabeth and then to Charlie to talk about it. This is really a webinar to help you figure out what you want to be doing in your states and an introduction to resources that you're going to have access to if you decide to work on this. So this is an opportunity that all of your states may decide to take advantage of, or they may not. But a formal notice hasn't gone out yet. We're trying to kind of get you in at the start. So before I turn this over to Elizabeth, I'm going to ask you to fill out this poll if you haven't done it already. And the reason why is just to give us a little bit of a sense of the audience and what your knowledge is. So if you should be all seeing this, have you heard about this initiative question? Please go ahead and respond, and then in a moment or two, we will move on with the webinar. I'm not seeing new responses coming in, so it may be. Let me close this. It may be that the poll feature got started too early and now won't take more, and we'll just move on. I'm sorry it didn't work. So Elizabeth, I am going to turn this webinar over to you. And thank you so much for being with us today. I think everybody in the audience knows Elizabeth. She's with the Georgetown Center for Children and Families, which does work on children's health and has been an incredible partner to me and to partnership members ever since the partnership got started up, and of course for you guys for years before that. A little known fact about Elizabeth is she actually spent some time at Arkansas Advocates, one of our members herself, so she truly gets the state advocate perspective. Elizabeth, do you want to start us off, please?
Sure. Thank you, Debbie, and thanks to folks for allowing us to talk about this timely topic. So we're here to talk about this new opportunity from Federal Medicaid's Innovation Center. And we've sort of split this webinar up into a few parts. One is why engage on this at all. It is very detailed and it's very program specific, and how do we think about this, especially for state advocates in a state and federal policy context. And just some of the basics about this opportunity, some things for child advocates to think about. And then I'm going to turn it to Charlie, and he's going to talk a little more about sort of the details and also some resources that he has really championed and started to put together to help stakeholders in every state that's really trying to think about this. And I should just say so many thanks to Charlie. He invited me to be a part of this discussion. He is really the workhorse behind a lot of the looking at this, and even before this opportunity was out, really getting folks together around a table to encourage Medicaid's Innovation Center to think about kids in a lot of these reforms, and especially when many of us were trying to work on the defense piece, really digging into these opportunities. So Charlie is really an unsung hero of keeping the attention on this issue. Speaking of which, I think one of the things that I think makes this also a great opportunity right now is that the election a few days ago and the change of control of the House means that we're at the federal level not going to be likely to be fighting very strong or cuts or changes to Medicaid, and that's a good opportunity too to freeze up a little more of our time to kind of think about innovative opportunities in Medicaid like this. So that is we might be having a different conversation had it gone the other way. So why engage on this? As Debbie mentioned, as a former child advocate, Medicaid is complicated enough, and then thinking about how to get in the conversations about Medicaid reforms that are happening can be very daunting for anyone, particularly for child advocates who may not work on this every day or even beyond coverage, even if they do work on it. Getting into the nitty-gritty of payment and delivery system reform is not simple and not easy, and is loaded with even more acronyms and terminology than we all think. So it's daunting. But there are, I think, and I would offer that there are opportunities to do this in a way that hopefully meets state advocates' capacity, and it's critical that we start to help influence these discussions because reforms are happening at the state and federal level, payment reforms, all of these, and with kids, the majority of, 40% or more, depending on how you think about it, of all children in Medicaid or CHIP, the majority of low-income children, we have to make sure that kids' needs are front and center. As many of you probably know, and I think seeing some of the participants in here, you're seeing it in your states, a lot of these conversations about be it value-based payment and payment reform or delivery system reform and all these hot terms and topics, they're not focused on kids. They're focused on adults and high-cost populations. And certainly if kids, not necessarily the healthy ones, and thinking about those upstream opportunities to prevent more complicated pieces down the line. And so there's a real need to be intentional about focusing on kids and reforms. I think New York did some great preliminary work as their state was looking at value-based purchasing and got some actuaries to look at, what would this take to do this right for kids, and it might mean more funding for kids when they're younger to make sure they're getting what they need in a prevention context. They're less expensive now, but do we need to rethink it? And with all these reforms really focused on saving money as well as positive outcomes, there's a need to elevate. You know what, we can't put reforms on children without thinking about what they need. We need them to be integrated into the reforms. So advocates, I think, are really important players here to say, well, how does this impact kids? We cannot put these reforms for the entire system onto kids without thinking about what their unique developmental needs are. And that's, I think, where advocates can be to sort of ask those questions and raise those issues. So this is really a concrete opportunity to engage and actually support your Medicaid agency and help them understand we're really behind your engagement on this. So what do you do when you don't have enough time to do what you're already doing? And this is yet another thing to think about. As I said, this is not about being an expert necessarily. This is about getting the right players to raising awareness about this opportunity, raising awareness about child development and what kids need, connecting. You all have, particularly since I think most, if not all of you, are multi-issue child advocacy organizations, you know the systems beyond the health system that need to be a part of these conversations, because this means not just limiting our systems change to healthcare, although they're a key player. You have those relationships with experts and folks in your state and child serving systems, and if you're anything like we were, you're good at getting people in the room and having some conversations about what this could look like. And last but not least, really trying to elevate and figure out how you get families and kids and parents' voices and perspectives integrated into this. Again, it's one thing to know that kids are not often a focus of a lot of these reforms. Beyond that, too, it's like, how do we make sure that the direct voices of folks who are going to be impacted during this conversation? And again, it doesn't necessarily mean you're the ones doing that work. It's kind of raising those issues with the right players. So here's an example. One question is, all right, under Medicaid's EPSDP, which is, of course, the Medicaid benefit for kids, states have to make sure kids are getting all the screenings they need. And this is one very basic question. Are kids getting their screens? Are they getting their well-child visits? And national data, which we can send to you by state, suggests they're not. They're not getting their annual well-child visits necessarily at the rate they should be. That should be 100%. And even at 88%, which looks better for kids under age 1, this data source counts 1 visit per year, and as you all well know, for kids under age 1, it's more like 8 visits that kids are supposed to have. So we'd be interesting to see what that percentage would look like if kids are younger. Or, I'm sorry, if they counted more visits during the course of the year. But my point here is these are the kind of data sources and questions you can raise to say, all right, we're looking at these reforms. Here's an opportunity to think about kids and a different way of doing business. Here's a concrete, here's what we want to know. Are we getting the preventive care to kids that we need? Are we, there are a lot of different data sources you could point to and raise as opportunities. Okay, So just considerations. The state, this might not be the right time or the right opportunity for the state, but that's where you can come in to at least raise it and start those conversations. Charlie will say more about this. The actual notice for this is not out yet, and we'll talk about that. But knowing what we know now, it's a good time to raise it with the agency, let them know you're supportive of trying to do this, to kind of put it on the radar before the actual opportunity comes out. And even if the state decides not to apply for this particular piece, or they do apply and don't get it, the mere opportunity of raising it and bringing it up and pulling the right folks together, there are a lot of things in here that you could do absent this funding opportunity, both in terms of Medicaid's flexibility and EPSET, and if necessary, looking at different waivers or other opportunities. So it could just be an opportunity to start the conversation regardless of whether or not the piece comes to fruition. Okay, I will briefly go through what this is. What is this model, and what folks can do? I think Charlie's been getting into a lot more of the details. So CMS, as part of the Affordable Care Act, created this Innovation Center to promote innovation in health payment and service delivery. One of its statutory requirements is for improved outcomes, but also to look at cost savings. And that has been one of the reasons it's been hard to get them sort of focused on kids, opportunities broadly for kids, including healthy kids for preventive care, because they have to think about that cost savings piece, and you're not going to see, if you look at all kids, necessarily savings in the near term, even though you certainly, I think you would all agree, you're going to see them in the long term. So their focus to date has really been on a lot of high cost and chronic care populations, specifically mostly adults. Outside of a few, they've done some pieces on high-risk pregnancies. There have been some child-focused, particularly for kids with special health care needs, funding opportunities within some larger ones. But the opportunity here, and this is a really big deal, which is of course why we're having this webinar, is this is the first effort specifically focused on kids and broadly looking at health, social, and behavioral health. So it's really an opportunity to look at kids through age 21. It's not focused on a specific health condition or piece. It's really thinking about how do we change the service and the payment delivery to make things work for all children. So it's $16 million for each state that gets a grant over 7 years, and Charlie can tell me if I'm messing any of this up. It's similar to the Race to the Top Challenge grants that you all might have engaged with during the last administration. The goals, which we didn't put here, but the goals are to improve child outcomes, to reduce hospital admission and out-of-home placement rates, out-of-home placements including foster care, and to consider new payment models to serve kids better. The fact that improved child outcomes is the first goal of this project is really exciting. It's not necessarily saving money as their first goal. The state Medicaid agency has to be a partner. They could be the grantee, or they can work with the lead organization for a community model. And I should say, I can't remember if it's on the next slide, but this is for piloting an approach in a local geographic area or multiple areas in a state. The frame of this funding opportunity is about opioids, the opioid epidemic. I think that it was under development before, thanks to folks like Charlie pushing and having this conversation. It was under development before a lot of the opioid piece came up, but that's the frame of the model, but it is by no means limited to opioid populations or addicted populations. I think that's much more the frame and trying to sort of think about how to meet children's comprehensive needs. I mentioned that one of the things they want to do is test alternative payment models. There is an inherent tension here. Well, and actually that was the next slide, but they want to try to think about how these payment models align with the risk for the children served. And so they want to look more broadly, but I'll talk a little bit more about this notion of risk stratification on the next slide. Importantly, the funding under this opportunity is only for planning and implementation. It's not for services. You have to use existing pots of money like Medicaid or 4E or others for the services themselves. So this is the inherent challenge I was jumping the gun on. There's this notion in the announcement, or the information we have now, that states have to sort of risk stratify, meaning they have to figure out how to target resources based on risks that they identify in children, and whether it's social determinants or whether it's other risk factors that come out of screens, and think about how these payment models would put the resources, more resources in these higher risk kids. I think the tension is trying to figure out how to do that and also serve the broader population and think about preventive care. And the tension is partially there because one of the requirements we think of this grant is going to be that states can't, this has to sort of be cost neutral. And so how do we think about redirecting some of those savings? And as I mentioned, particularly for young children and thinking about prevention context, it may be that we have to spend more on things like care coordination or primary care for children if we want to get this right. So that's part of the conversation. Since states have to serve in these models serve children 0 through 21, so there's not an opportunity to focus on particular age groups either, but that's where we have to think about these risks, this risk, quote-unquote, risk stratification piece. Okay, so there's preliminary information, a fact sheet out that we can send you if you don't have it already. We have a blog on our website, and Charlie's put a lot of great information together. As we understand it, I think Charlie's done a little more intel on this, Medicaid agencies are starting to think about this and their interests, trying to identify what communities might be ripe for this, which again, you all probably have a good sense about. It's not only in the health system, but other community partners. But I think it's still early. The funding opportunity is not out, so it's an opportunity to get in the door. I think it will be, as with any federal opportunity, a big, heavy lift to apply. So the more prep work and thinking that states can do now, the better. So we've said a lot of this, but if nothing else, if you do nothing else and you have limited time, there's really an opportunity to just raise this with your state Medicaid opportunities. Gauge their interest. Let them know that you would support this as an opportunity for the states to sort of be a leader in innovation and thinking differently about kids and elevating kids' needs in these reform contexts. And you all know who the allies might be, who the partners might be, who might be the experts to really lead the innovation and the design of what this could be, connecting the right people to the right places, thinking about what works. And I think this last point we can't say enough, even if it's not about this particular funding opportunity, just raising this, states can do a lot of the things that are raised in this opportunity regardless of this federal funding opportunity. And that's part of the opportunity here too. Is this is an opportunity that the feds are offering us, but by the way, we should be thinking about this anyway. So with that, I will turn it over to Charlie, who has lots more to say and some of the great resources I know that he is putting together to support groups interested.
Great, and thanks very much. And I'm probably going to reiterate a little bit of what Elizabeth said, but I'm going to try to go into more of the devil in the details and why this really is an opportunity, I think, for child advocates to weigh in with your passion and your knowledge to say that whatever the state does, whether it chooses to apply or not, and if it chooses to apply, how it develops its approach, it really has to look at this from the perspective of what can we do to improve child health from a more preventive as well as from a treatment perspective. I'm putting together, because I received some funding support, an InCKMarks network that is going to try to provide information to people around the application itself and what are some of these devils in the details. And specifically, while it's going to be for everyone, I really want to make sure that it meets the needs of people who are child health advocates and who are those champions and practitioners in the field who really are geared toward moving forward and want to do the work and really need to be a part of the process, because they're the ones that are going to know how this can be most effective. And then I'm going to speak about how child advocates can help. And what the InCKMarks is doing will provide an overall guiding framework on how to address issues and opportunities, and hopefully providing state and field information for your use. We're working with partner organizations, including the Partnership for American Children and Georgetown Center, in sharing those resources. And we really are seeking feedback from you and other champions in the field on what is going on with respect to this notification. And this funding opportunity really is, as Elizabeth said, is a first for the federal Medicaid office in singling out children and children's health, and wanting to do that in the context of being more preventive and developmental, as well as responding in a more cost-effective manner. As I see this, as I think talked with others in the field, and we've been connecting up with the American Academy of Pediatrics and other organizations on this, really the opportunities are that the model does identify the key issues that we know must be addressed to improve child health. We have to move beyond a strictly medical model of providing physical health care to kids to responding to family and home health needs, and strengthening the ability of the home environment to provide the nurturing care and stability that children need to grow up, and that this model will attract attention and stimulate planning in the field. This is something that I think all state Medicaid agencies will look at and say, this is something that is the direction that the field is going. Whether or not states want to be leads or do the whole piece, they're going to at least see that this is the area or the avenue that the medical world is moving in terms of child health. The challenges are, first, that the model is extremely ambitious in covering the entire prenatal to 21 years. And when I worked with other groups, we really recommended an early childhood health initiative rather than prenatal to 21, but they chose a prenatal to 21 focus, so you're going to have to deal with all of those developmental stages. There is this emphasis upon risk stratification and designing new payment models, alternative payment models, APMs, for high-cost populations. And this could easily take the majority of the attention and the time for states, but really the opportunity does exist, and I think the people in CMMI and others in the field are really hoping that an equal attention will be given to expanding preventive and developmental services for children under Medicaid, and that people will look at the long-term benefit and not just the short-term cost containment sides. And I think one of the real challenges that weighing in early can really help to address is that states do need to draw upon their child health advocates, experts, and practitioners in the field who are doing this type of work, maybe through grant funding or maybe through some additional support, or just because they know that it's the way they have to serve families and young children if they're going to succeed, that to make sure that they're part of this process and that their voices and ideas keep this on track with how we achieve better results for kids. What we're presenting in terms of our framework is that we need to recognize that we don't have to start from scratch, and we don't have to think that, oh, nobody knows how to do this, so somewhere at the top, if we give a managed care and accountable care organization resources and they develop some risk stratification and actuarial models, it's all going to work out in the end at the practice level. That we actually have a sound base of evidence-based practices, both for those high-cost populations where we can potentially achieve cost-saving or cost neutrality, and for preventive and developmental primary health care services. But this is going to require different types of practice changes and supports at different stages of development. And what we're going to be providing in the way of materials and supports is to say we know that there are effective and better practices that we can begin to incorporate into our health system in terms of service delivery and then financing. And here are 6 stages that we're going to be providing more detailed information on. The perinatal period, the optimal birth outcomes for mother and child, the birth to 3 period, which is really optimal physical health, secure attachment, early development of self-regulation, language and identity, 3 to 6 school readiness, and actually the 5 domains of school readiness are physical health and motor development, social and emotional development, approach to learning, language and literacy, and cognition really do fit into the definition of what we want health to be, and so on, that we can do something at each of these stages, that we can start with things that we do know work or can show signs of success, and we can build out with it in mind of that work. And so we're going to be providing something here is kind of just the devil in the details on birth to 3, that we know that our goal for birth to 3, and we'll have this information for each of the developmental stages that we selected. We want optimal physical health. We also want that secure attachment and that early development of self-regulation, language, and identity. And really, in this birth to 3 period, we can engage in child-specific activities, but unless we strengthen and ensure the safety, stability, and nurturing in the home environment, we're not going to achieve successful, healthy development and positive health trajectories. And as we look at indicators, and there will be a lot of emphasis upon developing measures and markers and performance measures and indicators, we are speaking in the first 3 years of life to no identified and untreated congenital abnormalities, body mass index, physical and language and cognitive and social and emotional development within normal parameters, no unplanned moves or foster placements, regular complement of well-child visits, and the developmental screens and social screens, including autism screening. We can, again, states don't need to start from scratch in trying to develop indicators and performance measures. But this next slide, which is fairly detailed and small type, but really hope will be used by you and others or built upon, is that we do know something about high-value preventive practices and what can go on in terms of comprehensive well-child visits that are based upon what is the law of the land, bright futures, that what we're talking about in terms of that more preventive and developmental practice in the earliest years, birth to 3, involves doing developmental and social determinants of health screening. And we have the Well Visit Planner, Reach Out and Read, Seek, and other tools that do exist already that states can incorporate into their expectations for well-child visits and for financing. We do know we need additional care coordination or targeted case management to children and families identified with some risk, and then follow-up linkages to them. And probably for the kids 0 to 3, it's more on that. I mean, there are kids, and I'll get to this, who have already developmental delays, environments where they're really vulnerable and at risk, or current health conditions that require fairly extensive services. But for a lot of the kids that we can really improve their health trajectories, it's more that they can benefit from additional social supports and activities that provide for that safe, nurturing, and stable home environment. And we have a number of program models: Help Me Grow, medical legal partnerships, Healthy Steps, My Child, home visiting programs of various types, as well as some systems that have really done this well for their whole populations. First Live San Diego, Primary Care Iowa, Maricopa Health Systems that really are performing in ways that are really improving that child's early experiences in healthy development 24/7 and not just through medical physical conditions. There are models that have created really strong linkages with Part C programs and other early response programs to developmental issues and concerns. Obviously, identified Massachusetts and Hawaii as being exemplary in developing their Part C programs in that way that is part of this health respond. And early childhood mental health consultation, just mentioned Colorado, Michigan, and Minnesota, and there are others that are really building that in. So there are high-value preventive practices that we know improve the trajectory of child health in these first 3 years of life. And similarly, there are high-value practices for risk-stratified populations that are intensive response services to families which are at risk of child placement and protective service involvement. And I think wraparound Milwaukee and New Jersey crisis response teams will actually be mentioned in the federal opportunity announcement, intensive family preservation services and the like, that we have something where we can really create more stability so that children can remain in their homes where they do best. That can be drawn upon. And there are a variety of intensive care coordination, parent training, and respite and support and assistive technology services for medically complex infants that can enable them to have much more normalized environments throughout the day, and also to reduce the likelihood of them having episodes that will require hospitalization or emergency room use. And we can, through risk stratification, identify those and use things like circle of support, care planning, family-centered medical homes with highly individualized plans, and family-directed care. And specifically, there are a number of models out now for kids who have asthma to provide home interventions, both training parents to be responsive and to removing household toxic environments that precipitate asthma that have shown to be cost effective. So the devil in the details, I think, is going to be as states look at this, is to make sure that they are recognizing that we can build upon practices that already exist, some in our state, some nationally, that can achieve the goals, and we can make it a concerted effort within our pilot to do so. This is a frame that Kay Johnson and I have used in a source book that we've developed that is really a companion to Georgetown's report on how Medicaid can finance early childhood services. It really speaks to, we know what a high value primary preventive practice pediatric medical homes is. We know that what happens when there are well child visits goes beyond weighing and measuring a child. And
a webinar. I think you should probably be on, frankly. No, I didn't loop you in. I was like, I'll join. And
I
was just coming in to say what I love probably.
Immunizations, and we know that for a significant portion of families, care coordination and case management that can strengthen the family's ability to respond and provide that home environment for their child that really is nurturing and developmentally supportive makes sense, and that may be 25 to 30% of all families. And we know that there are other services that Medicaid can and should finance or that are in the community that families should be able to access that can meet other needs. Some of those for concrete services in times of need, others for providing more integrated and responsive health services and care services, and that all of these really do represent activities that Medicaid can and should be financing. When Elizabeth said that at least 40% of kids are covered under Medicaid, and depending on different ways of measuring that, it's close to half or even 60%, and certainly in the early childhood space, it's that this is really not, this Medicaid, how Medicaid finances really does drive what happens in terms of pediatric settings. It's not like 10% of a patient population is Medicaid. It's the majority of kids are being served under Medicaid. So wanted to stress that. I want to go on and just say that what we're going to have in terms of what we're doing with our website and our other work is to try to create the content and the information that can provide support to you and others as you think about this application process, as you do your work. As I said, we have, on our website, we'll have our partners, and I've listed some of those. We'll have basic information about InCK that's provided by CMMI. We'll present our framework, and then we'll have more in-depth discussions and resources and syntheses around key issues that will be going to be addressed or need to be addressed, which we'll know a lot more about when the Notice of Federal Opportunity comes out. But for instance, opioids are going to be an issue, and we are going to want to have what are the programs that we know are effective in responding to opioid use, to avoiding opioid use among adolescents, to deal with young children whose parents may be involved with opioids or other substances and the like. And the last two is really contacting, giving us feedback, and knowing what we can do in the way of providing webinars and other things in order to be of help to you. Right now, I mentioned, and I think that there are two resources that will be helpful in looking at what you can do. Elizabeth has just done a great piece promoting children's healthy development in Medicaid. And as I said, Kay Johnson and I, through the Center, the Child and Family Policy Center and the Health Equity and Young Children Initiative, has done a source book on Medicaid's role in early childhood, both of which really enumerate what Medicaid can do. And I think in the context of everything I've talked about, it's not that Medicaid right now can't finance care coordination. It can't finance a high-performing medical home. It can't finance directed referrals for dyadic therapies and home visiting. In fact, Medicaid is structured with its EPSDT benefit to provide those. But right now, states have not moved out by and large to expand Medicaid or create the options of really providing in a fulsome way for those preventive developmental services. This is just the outline of the report that Elizabeth Brock did, and it's on Georgetown's website. And this is the outline of my source book on Medicaid's role in early childhood, which, as you see, has 7 parts and go into a lot of detail over what is the EPSDT benefit, what are the different ways of providing care coordination and case management, and how we can optimize payment approaches. One of the things that we emphasize in our work is that value-based care is not cost containment care. Value-based care means we're going to provide greater reimbursement and more incentives and more directions to practices which are of high value rather than low value. And all primary care that's practiced today with children has some value, but care that also responds to social determinants of health, that is more preventive and developmental and interactive with families, has a much higher value, and we have to provide means for incentivizing and making that, rather than exemplary practice, in the mainstream and standard expectations for care. I think Elizabeth and I and Debbie all think that the presence of this InCK model as a very significant federal initiative in the space of child health, which they have not done before, which is really directing Medicaid agencies to look at child health from a much broader perspective than medical care, really does create a catalyst for activities within states to take action. So I want to then turn this back over to Debbie, and I think that Elizabeth and I can try to respond too, but really want your thoughts, reflections, ideas, and advice, and really what would be most helpful to you in terms of having information or resources, and and is this something your state is considering, and how can you be best engaged? So I'm going to turn it back over.
Great. Thank you, Charlie. So first of all, I want to say to everybody that before we start an open discussion, which we will do, I do want to take any questions you have about the technicalities of it. The way to do that, as I said before, is you go to the bottom left of the screen, you pick your chat recipient, which can either be all presenters or me, and I'll read it out loud, or everybody, and just type in your question and then hit send. And we'll answer your technical questions, and then we'll move on to the discussion. And while people are thinking about that and putting in questions, Charlie and Elizabeth, I want to just make sure that my understanding of this opportunity is right, and kind of not the policy part, but what it means strategically. I want to kind of say it and make sure that we've got this all right. So this proposal is going out to all 50 states, and only 8 states will be selected. The proposal itself may be right for your state, or it may not be, but either way, you may want to be involved in the discussion of whether they should submit and what that submission should look like. And even if they don't submit, it opens the door to a discussion about many ways you can use Medicaid that they aren't currently using it that would help kids. So that's my first part of it. My second part is that once they pick the 8 states, those states, there may be opportunities for advocates in those states to get funding to work with their states on the planning process. And so if you engage early in it now and your state gets selected, this would open the door potentially, we hope, for the resources to do the work you'd need to do as they do the planning. Is that all an accurate statement strategically of what's going on here?
Yes, thanks, and I'm really glad you emphasized that, Debbie. I have talked with the people at CMMI, and this grew out of a request for information that they sent out, and they got hundreds of responses, but really they did build this grant proposal on the responses of groups like the Partnership, the Health Equity and Young Children Initiative, Georgetown, Manat, Families USA, Help Me Grow, the American Academy of Pediatrics, the American Association of Community Health Centers, so that they build it off this. It's going to probably, the notice of federal opportunity will come out in about a month. they haven't given an exact timeline for that, but really we're hoping that people will contact their aid states before the NOFA comes out, because once it comes out, I think people are going to be looking at how do I respond to Section 2G rather than what do I want to do with this overall opportunity. And it allows you to weigh in. And then there'll probably be a 3 to 5 month period where states will have the opportunity to apply. I noticed one question just around waivers. I think that this is going to be an initiative that is focused on a pilot geographic area. So it certainly may be done through a waiver, and that it would certainly be something that I think, given the amount of work and planning, that the expectation is that it would be accepted if it's confined to a geographic area. I would say that from what I've looked at in terms of all the work, there is going to be nothing that states can't do through either if they want to do something statewide through a plan amendment, or if they want to do something on a more targeted area through a waiver, without getting the actual receipt of the funding, but they then have to come up with the planning and implementation and design funding. So there's an incentive because of the $18 million, but there's nothing that is going to be something that if you don't get this grant, that means that you can't implement either service reforms and alternative service models, which I think CMMI is going to stress for that more preventive population, or alternative payment models for that much narrower stratified risk, high cost population.
Elizabeth, do you want to add to that?
I did. I wanted to just clarify. I think nothing in this, as I understand it, proposal requires certainly an 1115 or a waiver, or even a SPA. I think the opportunity here is that this is some planning money focused on a specific geographic area where you can unpack what is necessary and whether it will be necessary to do any of that. I think one of the things about EPSDT that we often have struggled with is there are a lot of things you can do without waiver, not statewideness aside. There are a lot of things you can do even without a SPA change potentially, but definitely without a waiver. And so I think this is a great opportunity to take a really close look at a delivery system in a particular area, unpack what's needed, and then assess all right, these are the changes we want to make. Is that, with state officials, is that going to require a waiver or a SPA, or is it something we can go ahead and do? Maybe, how does this work with statewideness? So to me, I think this glue money, if you will, this planning money, helps to kind of really unpack those conversations that are not always easy as you're thinking about the challenges for kids in the current delivery system. And I don't know, Debbie, if you want me to, I'm looking at other questions that I could try to take a crack at if that helps.
Yeah, I think it would be very helpful if you could tackle Devin's first question.
Yeah, that was
Go for it.
So we had a question on...
I'm not sure it went to everybody. If you can read it out loud, that'd be good.
I will look. So one state is saying that they are pretty sure their Medicaid agency is going to be interested, and they want to help them and work with them. And what are the things that that they might be able to anticipate or help prepare for the state? So Charlie will probably have more thoughts on this. My initial thought is this, that I think you all have a good line into what a lot of the challenges are, whether it's in your managed care system or whether it's looking at EPSDT data or other data and saying where are the real gaps in what kids are needing, or what do we need to better understand whether our referral systems are working, that kind of thing. And I think that at a minimum, kind of unpacking and talking to folks on the ground that are doing this work or doing innovative work, and trying to get what they think are the most important places for the state to emphasize in thinking about a new type of model. And again, just trying to kind of gather and translate some of that information to the state about what the opportunities are and where the gaps are in your system. But Charlie, that and also what are the places in your state geographically you think are ripe for this, trying to think through this, that are doing some interesting things or want to do different things a little differently but can't because of some of the constraints in Medicaid potentially. So I think that's kind of how to start thinking about it. Until the notice of funding comes out, I think there are probably more you might have in terms of looking at data or that kind of piece. But Charlie, what would you add to that?
Well, I do think that it's going to be required that, and I see the question around can we do it statewide. I don't think that they're going to allow that. They're going to, they want to have a geographic area because they really want to make sure that this is going on in a place where they can look at population-wide impacts and that there's a readiness and that there's an ability of cross-sector involvement to be going forward. I think that I put this slide back up for of the Georgetown report because I really would recommend it doing homework in going in the familiarity with what can we do as far as funding and financing under Medicaid to review the Georgetown report and then to slog through as much of it as you can of our Medicaid's role in early childhood. And I'd love to have feedback, and Kay would too, on that. But it really tries to be, here's how far the field has advanced, and here are some of the specific things that can be covered. And it really does try to take the perspective, as Elizabeth does, that it's not just that Medicaid technically can allow you to do some things in terms of more preventive and developmental services. It's that the EPSDT benefit really does direct states to be doing this, and we have to begin to utilize that more effectively. I think those two pieces, and then I think Nemours has a good paper on kind of the how of engaging with Medicaid agencies around that. The emphasis in this proposal will be on kind of that, how can we improve health and contain costs, but it really is going to be around Medicaid and CHIP populations. And so I think that we're trying to give you as much as you can so that you can really talk to people who are in the Medicaid agency and have a background on some of the issues around Medicaid and what Medicaid rules and regulations really do, both enable states to do and expect states to do, and then how sometimes they're then implemented very narrowly so they may not be achieving those purposes.
Thank you. So I've taken us back to your slide which had questions for the group. And I'm actually going to say at this point, if people would like to comment verbally, that's fine. You can unmute your phone by using *7. And Charlie really had two questions. Let's start with the first one. What would be most helpful to you? Does anyone have a comment on what they would like to see this project do, what would support them? And I'm going to add, when you think about it, it might be helpful to say whether you need it before the notice comes out or just during the period where the states are responding to the notice. So does anyone have any requests or suggestions for what we can get you that would be helpful? And if you want to unmute, you use *7, sorry. We're not getting answers here. Devin does have one more question, but before we get to it, I would like to ask, does anyone besides Devin know whether this is something your state is considering? And you can either just speak, or you can type a response to everybody in the Q&A.
Can you guys hear me? This is Kristen.
Hey, Kristen. Yes, we can.
Hi, I'm calling from California, and I'm just digging through all the great reports that Georgetown did and Charlie did. They did. They're fantastic. And maybe this is in there, but I think would be really valuable is to really see examples of states, and I think that some of the programs that you listed, but just in one place, like here are some pools of programs that have worked both on the level of the program, the level of the what are the measures used, and those different pieces that have been effective, so that we can kind of pull from those if we don't have them in our state. So some best practices to kind of point to and reach for.
That's really helpful. Thank you. Does anyone else have something that they'd like to see that they would use if it was created that would help them with this project? So while people are thinking about that, Charlie, Devin has a question for you, which is the full source book available? And she only has the introduction link. Is this the email that I sent out for you on the listserv, or is this a different material? Charlie?
Oh, and I mean, is that the source book is on the Child and Family Policy Center website, and they did a great job of putting it together and then breaking it out so you can download the executive summary, or you can download part 1 or part 2 or whatever, so you don't have to download as you need it. But there's also at the beginning, I think there's something that says if you want the full report, download here. So you can download the full report, but you can also download just a section at a time, or the executive summary.
So that's great. Elizabeth just found it apparently and posted it. But
I did.
if you can also send it to me in an email, Elizabeth, when I send out the slides and the webinar recording, I'll include this link for people as well, well as your blog. So that would be great. And then also, Charlie and Elizabeth, apparently New York is considering applying. I don't know if you noticed Bridget's note there, but New York is also interested. And then Rita Furlow has typed an answer about what she would find helpful, which is additional resources on EPSDT and how other states have successfully utilized it in creative ways. And Elizabeth, I know Georgetown's been doing a lot of work on EPSDT. Do you have a report that talks about how states have used it successfully?
To some degree, it is I think one of the challenges of collecting data like that, or examples that are specific to EPSDT, I mean, a lot of them are in the report that I did and some others, and I'll send some of those to Debbie, is that every state's so different in terms of its delivery system and how to interpret the EPSDT, so that's what makes that challenging. But what I will do, we have a primer on EPSDT, we have some other resources. We've also been doing a project with the American Academy of Pediatrics, trying to help both educate on what EPSDT means and how it's sort of this underutilized potential resource. And we have 3 webinars, one on sort of the basics, one on medical necessity, which is where we get a lot of sort of questions and get caught up on whether kids are getting the treatment they need in states. And then we have our third webinar was on when and how to engage the legal community on EPSDT. I think those are the most rich sort of resources in terms of understanding the context for what I just said about it's hard to find an apples to apples. That said, we have some examples, and we will continue to find those. I think the easiest thing to say is so much of the EPSDT and best practices comes down to kind of how and where managed care plans play a role, and whether the state is sort of really providing oversight for that and requirements in those contracts. So that's a whole other conversation we could have. So I'll send those to Debbie, and as well as the EPSDT resources.
Great. If you put that all together, I'll send a slide to all the participants, the slides, the webinar recording, and all the resources you mentioned, and Charlie's source book and your blog, and I'll get it out to everybody. Do we have anyone else with questions? And Charlie, I know you want to say something, and then we're actually a little past our time, so we'll have to get off. But before that, Charlie, did you want to add to anything?
Just that the source book has a fairly detailed description of the EPSDT benefit. It is a benefit which is required for states to provide, and it does cover a lot of different things. And the source book also has a lot of examples of preventive services or developmental services or the type of care coordination that can be covered under Medicaid that would contribute to meeting the EPSDT benefit standard. So I really want to emphasize that I think that this is important, but it's core to Medicaid, and there are preventive services that can be offered and defined by states, whether they're EPSDT or they're just Medicaid benefits that go to children, that those are clearly among the overall broad expectations for Medicaid.
Great. The only other thing I do want to say before we get off is that for all the partnership members, we do have our partnership policy listserv. If you're not on it and you want to be, email me. That's a good place to raise comments and questions where you're interested in information from your peers around the country, and wherever it seems helpful or appropriate, I will share that information with Charlie and Elizabeth and bring you back what they say. But that's a good place as you guys think about this, work on this, to just kind of put comments out there and get reactions from your colleagues around the country. So having said that, Elizabeth, do you have any last words before we get off?
I know this is a lot, and like I said, it's good to have on your radar, and if nothing else, it's worth raising with your Medicaid agency and offering this as an opportunity for the state to lead the way on thinking about kids and how Medicaid can work for them.
Great, thank you. And I will get the recording out pretty quickly because this is a more than usually technical webinar, so I suspect some of you might find it helpful to replay it or to go over the slides. So we'll get you all of that information just in the next day or two so that you can be thinking about it. And Charlie, I'm going to ask as a final commitment from you that as soon as the notice is public that you let me know so I can let everyone know. Is that something you're willing to commit to?
Yes.
Great. Thank you both so much, and thank everyone for joining us today. This webinar is now over, and I will share the recording and the materials with everyone. Have a great day, and I hope this was helpful to you. I'm going to close the recording.